When someone undergoes a procedure to have a coronary stent implanted, there's a widespread belief that the difficult chapter has closed. In certain respects, that's accurate. The obstruction has been cleared, circulation has been restored, and the immediate danger has subsided. Yet here's the reality that rarely gets adequate attention. The actions you take during the 12 months following that intervention will largely dictate whether you maintain your health or find yourself facing another emergency procedure. And there's a second critical truth that often goes unspoken. A stent isn't a definitive solution to your cardiovascular disease. It's an opportunity to begin again. How you capitalize on that opportunity rests entirely in your hands. Let's revisit the fundamental problem because grasping what a stent accomplishes requires first understanding the underlying pathology. Your arterial system consists of hollow channels that transport oxygenated blood from your heart to every tissue and organ throughout your body. When these channels remain unobstructed and flexible, your circulatory system functions optimally. However, across many years, sometimes spanning multiple decades, a material known as atherosclerotic plaque gradually accumulates along the interior surface of these vessels. This plaque represents a complex mixture of lipid molecules, calcium deposits, fatty substances, and inflamed tissue. The accumulation doesn't happen suddenly. It progresses slowly and without symptoms, comparable to how mineral deposits gradually narrow water pipes over extended periods of use. The medical terminology for this progressive buildup is atherosclerosis, which literally translates to the hardening and constriction of blood vessels caused by plaque deposition. As this material expands, the interior diameter of the artery diminishes. When that opening becomes reduced by approximately 70%, the cardiac muscle begins experiencing insufficient blood supply during periods of increased demand. This is when you experience tightness or pressure in your chest during physical exertion. This manifestation is termed stable angina, meaning the vessel has become critically narrowed but hasn't completely occluded yet. Now consider what happens if that accumulated plaque becomes unstable. If the fibrous cap covering the plaque tears or ruptures, your body initiates its standard response to any vascular injury. It dispatches platelets to form a clot at the site of rupture. When you cut your finger, this clotting mechanism serves a protective function. Inside a coronary artery, however, it becomes a life-threatening event. The clot forms rapidly over the ruptured plaque surface and the artery becomes completely blocked. Blood flow ceases to the region of heart muscle supplied by that particular vessel. This is what constitutes a myocardial infarction. The term myocardial refers to the heart muscle itself. Infarction describes tissue necrosis resulting from interrupted blood supply. The element that carries the most weight here is the temporal factor. If the blocked artery can be reopened within approximately 4 to 6 hours from symptom onset, the majority of cardiac muscle cells remain viable. But if 12 hours elapse with persistent occlusion, most of those cells undergo irreversible death. They cannot regenerate. Instead, they're replaced with fibrous scar tissue. This scarring can ultimately lead to a weakened segment of the ventricular wall called an aneurysm, a dilated, non-contractile area that permanently compromises cardiac function and efficiency. This is precisely why coronary stenting exists and why the rapidity of deployment matters so profoundly. The inaugural coronary stent implantation occurred in France during 1983, performed by two pioneering interventional cardiologists. That initial device was relatively primitive by contemporary standards, essentially a bare metal framework, nothing more sophisticated than that. Yet it proved effective enough to reopen an obstructed artery and maintain patency. Throughout the subsequent 4 decades, stent design has undergone an evolution that is genuinely extraordinary. Contemporary coronary stents aren't simply metal scaffolds. They're coated with a specialized polymer, a thin, biocompatible layer that contains a pharmaceutical agent classified as a cytostatic compound. Cytostatic refers to substances that inhibit cellular proliferation. This might seem paradoxical at first glance. Why would you want to suppress cell growth inside a healing blood vessel? The answer lies in the complications observed with earlier generations of devices. When the initial bare metal stents were deployed clinically, a substantial proportion of patients developed a complication termed in-stent restenosis. Restenosis indicates that the artery narrows again, not from new atherosclerotic plaque formation, but because the body's healing cascade triggered excessive cellular proliferation over the metal struts, eventually re-obstructing the lumen. This phenomenon was particularly prevalent in diabetic patients, whose vascular smooth muscle cells tend to multiply more aggressively in response to injury. The drug-eluting polymer coating addresses this complication elegantly. It releases the antiproliferative agent gradually and locally into the surrounding arterial tissue, maintaining cellular growth at a controlled rate that allows the stent to remain patent without interfering with the natural process of the vessel wall healing around the device. Modern drug-eluting stent technology has reduced restenosis rates dramatically from roughly 20 to 30% with bare metal devices down to single-digit percentages. This isn't merely an incremental improvement. It fundamentally transformed outcomes for millions of patients annually. There's a well-documented pattern in interventional cardiology that plays out regularly. Consider a patient, let's call him Michael, in his late 50s, who presents with progressive chest discomfort whenever he ascends a flight of stairs. Diagnostic stress testing confirms significant coronary artery disease affecting a major vessel. He undergoes stent implantation, and within a matter of days, the chest pressure that had been gradually worsening over several years simply disappears. Michael feels remarkably better so quickly that he begins questioning whether he truly needs to continue all his prescribed medications. That decision, made privately and with entirely understandable reasoning, represents the point where many post-stent trajectories take a dangerous turn. We'll return to Michael's story shortly. A prevalent concern among individuals who've recently undergone stent placement is that the device might somehow dislodge or migrate within the vascular system. This anxiety is entirely understandable. You have a small metallic structure positioned inside a major artery, and your heart is in constant rhythmic motion. But here's what actually occurs during the implantation procedure. The stent is mounted in its compressed state on a specialized balloon catheter. That catheter is advanced through the arterial system to the precise location of the obstruction, with the position confirmed using real-time fluoroscopic imaging. Once correctly positioned, the balloon is inflated to pressures ranging from 10 to 16 atmospheres, which represents substantial mechanical force, and the stent is expanded forcefully against the arterial wall. It doesn't simply rest against the inner surface, it becomes embedded into it. Interventional cardiologists also employ intravascular ultrasound technology, a miniature imaging probe inserted inside the artery itself, to verify that the stent is appropriately sized for the vessel diameter and fully apposed against the arterial wall throughout its entire length. The stent diameter is meticulously matched to the true dimensions of the native artery. It becomes essentially a permanent structural component integrated into the vessel wall architecture. It doesn't shift position, it doesn't float freely, it's mechanically anchored in place through radial force. There's a noteworthy distinction between stents deployed in the coronary circulation and those placed in other vascular territories, such as the carotid artery in your neck or the iliac arteries in your pelvis. Coronary stents must possess a specific balance between radial compressive strength and longitudinal flexibility. They must resist the constant compression forces generated by myocardial contraction without fracturing or becoming kinked. However, they're not entirely rigid structures, and under extreme mechanical stress, they can potentially be deformed, which is why stent placement in coronary arteries is always strategically planned to avoid vessel segments subject to significant external mechanical forces or acute angulation. Stents deployed in carotid or iliac vessels, by contrast, are typically self-expanding devices and essentially crush-resistant. You can compress them substantially, and upon release, they return to their original configuration. This design philosophy is intentional. Those peripheral vessels undergo significant movement with body position changes, flexing with neck rotation or hip motion, and require a device that can tolerate that mechanical stress without losing structural integrity. Now, returning to Michael's situation and to the single most critical concept you need to understand about the post-stent period. When a stent is initially deployed, your immune system and clotting cascade recognize it as a foreign material. That recognition activates the thrombotic system, the same biological response that would react to a splinter embedded in your skin or a laceration. Platelets, the small cellular fragments responsible for clot formation, begin accumulating around the exposed metal struts of the stent. If this process proceeds unchecked, a thrombus can form inside the stent, completely occluding it. This event is called stent thrombosis, and when a stent thromboses, the result is typically an acute myocardial infarction, frequently more devastating than the original cardiac event that prompted stent placement. The strategy modern cardiology employs to prevent this complication is called dual antiplatelet therapy. Dual signifies two separate medications administered concurrently. Antiplatelet indicates these drugs inhibit platelet activation and aggregation. The two agents most commonly prescribed are aspirin, typically at a low dose ranging from 75 to 100 milligrams daily, and a second agent, either clopidogrel or ticagrelor, being the most common choices. These medications work through different biochemical pathways affecting platelet function, which is the entire point. One drug blocks one mechanism of platelet activation, the other blocks a completely different pathway. Together, they provide redundant inhibition of the clotting cascade. Think of it as having two separate locks on the same door, providing layered security. The reason this therapeutic strategy matters so profoundly relates to the biological timeline of stent healing. During the initial weeks and months following implantation, the metal struts are gradually becoming covered with a new layer of endothelial cells, the same type of specialized cells that line healthy arteries naturally. This biological process is termed endothelialization or re-endothelialization. Once the stent becomes fully covered with this new cellular layer, typically over approximately 12 months, it becomes essentially incorporated into the native arterial wall and the thrombotic risk diminishes substantially. But until that healing process reaches completion, the stent remains thrombogenic, meaning it has a tendency to promote clot formation. This is why missing even a single dose of your antiplatelet medication during the early months after stenting carries genuine risk. There's no buffer period built into the system. One missed dose eliminates your protection for that entire day. There is extensive clinical data and decades of accumulated cardiology experience demonstrating that abrupt discontinuation of dual antiplatelet therapy during the early post-stent period represents one of the most common precipitating factors for stent thrombosis. The clotting system, which has been pharmacologically suppressed, rebounds rapidly once drug levels decline, and a thrombosed stent constitutes a true medical emergency requiring immediate intervention. This scenario presents in emergency departments more frequently than most people realize. An individual who underwent stent placement 8 or 10 weeks prior felt completely normal and quietly discontinued one of their antiplatelet medications because they ran out of tablets or didn't perceive it as particularly important. They arrive at the emergency room experiencing a massive acute myocardial infarction, the very event the stent was intended to prevent. This is Michael's story, and it unfolds in hospitals throughout the country with unfortunate regularity. After completing 12 months of dual antiplatelet therapy, and this transition should always occur through discussion with your cardiologist, never as an independent decision, many patients transition to aspirin monotherapy as indefinite long-term treatment. Some individuals may require extended dual therapy beyond 12 months, depending on their individual risk profile and clinical characteristics. But the first year of dual therapy is absolutely mandatory. There are no exceptions to this principle. Now here's the fundamental reality. The stent addresses the mechanical consequence of atherosclerosis. It does not address the underlying disease process. And this represents the aspect of post-stent care that frequently gets overshadowed by the relief of surviving a cardiac event. The plaque that obstructed your artery developed because of a constellation of modifiable and non-modifiable risk factors. Elevated low-density lipoprotein cholesterol, which is the specific cholesterol fraction that contributes directly to plaque formation. Elevated blood glucose levels, which damage endothelial cells and accelerate atherosclerotic progression. Elevated blood pressure, which creates repetitive mechanical injury to arterial walls, making them more susceptible to plaque development. Cigarette smoking, which directly injures the endothelium through multiple toxic mechanisms and promotes inflammation at every stage of atherosclerosis. These pathological factors don't vanish simply because you now have a stent in place. If these risk factors continue operating without modification, atherosclerotic plaque will continue forming in the stented artery around the margins of the device or in other coronary vessels entirely. The probability of requiring additional interventional procedures is real and quantifiable. It's not inevitable, but avoiding it requires active, sustained risk factor management. Cholesterol-lowering medications, primarily statin drugs, are almost universally prescribed as part of post-stent medical therapy. Managing blood glucose is equally essential, particularly in individuals with established diabetes or pre-diabetic states, because chronic hyperglycemia accelerates vascular injury through multiple mechanisms that no amount of stenting can compensate for. Blood pressure optimization, complete smoking cessation, and regular structured physical activity all directly reduce the rate at which new atherosclerotic lesions develop. These aren't optional lifestyle recommendations. They represent the medical continuation of the treatment that began with your stent. Regarding physical activity specifically, this is an area where unwarranted fear prevents many people from pursuing appropriate rehabilitation. If you underwent stent placement for stable angina or an uncomplicated myocardial infarction, and you don't have a ventricular aneurysm, and your left ventricular function has been assessed and remains adequate, most individuals can and should return to regular exercise. Walking represents an excellent foundation to begin with. In many cases, following proper evaluation and with guidance from a cardiologist or cardiac rehabilitation team, people successfully return to running, cycling, swimming, and other sustained aerobic activities. Exercise isn't merely permitted after stenting, it's actually part of the therapeutic intervention. Physical activity improves endothelial function through multiple molecular pathways, reduces blood pressure, enhances insulin sensitivity and glucose metabolism, and reduces overall cardiovascular risk across virtually every measurable parameter. The specific details of what intensity and duration are appropriate for your individual situation need to be determined collaboratively with your medical team. But don't operate under the assumption that having a stent means you must remain sedentary or avoid exertion. Frequently, the opposite is true. There's a scenario that arises regularly in cardiac rehabilitation programs. Consider a woman, let's call her Susan, in her early 60s, who underwent stent placement after several years of exertional chest discomfort. During the months immediately following the procedure, she was extremely cautious about any physical exertion. She moved slowly, avoided climbing stairs, stopped her neighborhood walking routine entirely. At her 6-month cardiology follow-up appointment, her physician cleared her for a graduated supervised exercise program. Within 3 months of beginning structured activity, Susan completed a 5-kilometer charity walk. She described her exercise tolerance and stamina as superior to what she had experienced in over a decade. This outcome isn't unusual or exceptional. It's actually the expected trajectory when post-stent care is implemented properly. This is also an appropriate point to address the cholesterol management conversation in detail because it's frequently misunderstood or inadequately explained. Following a coronary event or stenting procedure, the therapeutic target for LDL cholesterol becomes more aggressive than the goals recommended for the general population. The standard recommendation in secondary prevention is maintaining LDL below 70 milligrams per deciliter, which is a concentration measurement of how much cholesterol is circulating in your bloodstream. For individuals at very high risk, the target may be even lower, below 55 milligrams per deciliter. Dietary modification alone rarely achieves these targets following a cardiac event. Statin medications such as atorvastatin or rosuvastatin are typically required to reach these therapeutic goals. And the evidence base supporting their use in this clinical population is robust, spanning multiple large randomized controlled trials and decades of outcome data. If you have concerns about potential side effects or tolerability issues, those are legitimate conversations to have openly and transparently with your physician. But the clinical decision to manage cholesterol aggressively after stent placement is firmly grounded in high-quality evidence demonstrating reduced mortality and reduced recurrent events. Here's something worth considering that connects to everything we've discussed. What's your current age? Age genuinely influences nearly every dimension of post-stent recovery, from the rate at which endothelialization occurs over the stent struts to what level of physical activity is physiologically appropriate to how aggressively certain cardiovascular risk factors need to be targeted. Understanding the age demographics of the audience helps tailor information more effectively. So what does successful living after a stent actually look like in concrete, practical terms? It means taking your prescribed antiplatelet medications every single day without exception, particularly during that critical first 12 months. It means having a clear understanding of your specific LDL cholesterol target and what therapeutic interventions you're using to achieve it. It means knowing your blood pressure readings and maintaining them within optimal ranges, typically below 130 over 80 millimeters of mercury for most patients, potentially lower if you have diabetes or chronic kidney disease. It means complete tobacco cessation, and if you currently smoke, making a genuine supported attempt to quit using evidence-based cessation strategies. It means progressively reintegrating physical activity into your daily routine, starting at appropriate levels and advancing on a timeline that your medical team helps you establish. And it means recognizing that every follow-up appointment represents an opportunity for optimization, not merely a formality to check off. A stent is not a life sentence of disability or limitation. It is, as countless cardiologists who follow these patients longitudinally will attest, a genuine second opportunity. 3 or 4 decades ago, an acutely occluded coronary artery frequently meant death or permanent cardiac disability. The therapeutic options were severely limited: bed rest, anticoagulation with unfractionated heparin, and if the patient survived the acute phase, a major surgical procedure called coronary artery bypass grafting, where a vessel harvested from another part of the body, typically the saphenous vein from the leg or the internal mammary artery from the chest wall, is surgically attached to bypass the obstructed segment. That operation required a full sternotomy, literally sawing through the breastbone, and placing the patient on cardiopulmonary bypass, a machine that takes over the function of the heart and lungs during surgery. It was a lengthy, high-risk operation with substantial morbidity and prolonged recovery. Today, that procedure is reserved for only the most anatomically complex cases, typically involving multiple vessel disease not amenable to percutaneous intervention. Currently, roughly 1 in 150 cardiac patients require surgical bypass. The vast majority can be managed endovascularly, meaning through the artery using catheter-based techniques, without opening the chest cavity at all. That paradigm shift in cardiovascular medicine occurred within a single human generation. The technology now residing in your coronary artery represents the culmination of over 40 years of relentless biomedical engineering and rigorous clinical science. Use that technology wisely and to its full potential. Take your medications exactly as prescribed. Actively manage your modifiable risk factors. Attend your scheduled follow-up appointments. Have frank, honest conversations with your cardiologist about what activities you can safely pursue and what limitations, if any, actually apply to your specific situation. Push for clear, evidence-based answers because you absolutely deserve them, and your long-term health depends on having accurate information. Everything presented in this discussion constitutes health education information. It's designed to help you ask more informed questions and better understand the answers you receive. It is not and cannot be a substitute for the individualized medical advice provided by a physician who has direct knowledge of your case, your imaging studies, your laboratory results, and your complete health history. No online educational content, regardless of quality or depth, can replace that personalized clinical relationship. The opportunity you've been given through modern interventional cardiology is extraordinary when viewed against the historical backdrop of cardiovascular medicine. The 12 months following your stent placement represent a critical window during which the biological healing process occurs, and during which you establish the behavioral patterns and medical adherence that will shape your cardiovascular health for potentially decades to come. Approach that window with the seriousness and intentionality it deserves. Your future health is not predetermined by the fact that you needed a stent. It's largely determined by what you do in response to receiving one.